Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center. Welcome to today's program. You will be, you can go to the next slide, that's all right. So again, this is a free webinar series. We have continuing medical education credits for this, and there's some information that will go out in the thank you email if you've been with us before. And the next slide. So as the webinar tips, as you joined us today, your phone or your computer microphone were muted. Please go ahead and use the chat function for Q&A. So we'll keep an eye on it in the background here for any questions that you have for Carol, our speaker today. Please fill out that post-webinar evaluation. That's very important for us because that gives us ideas for our next webinars coming up. So that will be that will come up behind this screen at the end. I will also send it in my thank you email to everybody that has joined us today. CME credit is only available for the live presentation. It is being recorded, and the recordings will be on our website. I will have that URL in my thank you email as well. You don't have to worry about trying to copy it right now. Next, please. So these are the CME information, the outcome objectives, the accreditation statement, disclosure statement, and the attendance tracking code. So for specific CMEs or MDs and DOs, you can set up your profile, and there's in the evaluation, there's a code that you get to text in, and you can keep that same account with the university as continuing medical education office for any future webinars, and you will be able to print out a transcript. Those of you that would also like some kind of a participation certificate, you'll be able to respond to my thank you email when we are done. Go ahead, next slide. So without any further ado, I get the pleasure of introducing Carol Yarbrough. She's been with us for many, many years, and she's going to be talking about the updates for the 2026 MPFS, which is the Telehealth Billing and Reimbursement. So Carol, go ahead and take it away.
Thank you very much. And again, it's a pleasure to be here with the Arizona Telemedicine Program, the Southwest TRC, and all of the Yarbies in attendance. We were making the joke beforehand that some people attend just to hear my dulcet tones. So I just declared you are now Yarbies instead of Swifties. I'm so narcissistic. Disclaimer, these are my opinions always, not anyone else's. Yeah, just me, and maybe CMS and maybe some other folks. Again, the learning objectives, we are going to be focusing a lot on the conversion factor and why there is budget neutrality. You're going to be able to name 2 positive results of the Medicare physician fee schedule and by the end of this, and maybe I kind of feed them to you so well that you'll be able to just reel them off and explain where an originating site location can be ascertained and why a patient's location at home or in a facility determines payment. Well, payment and how much you get paid. I'm going to get a few things out of the way first. And I'm going to keep myself on track. I have 51 slides. It's just absurd. Okay. The slides are going to be provided, people. They're going to be provided as well as a recording. I want everyone to relax. Just relax. Nothing is constant. We're going to develop flexibility when we're dealing with telehealth, right? Flexibility with the MPFS because it's proposed. You're going to find a support system. We're your support system. We're here to help you weather this next month and a half. Okay, yes. And you're going to reframe some challenges as opportunities because I'm going to talk about the elephant in the room. The expiration of the telehealth flexibilities afforded to us at the start of the pandemic, the public health emergency in 2020. Now, this is an excerpt from a webpage. Does it look familiar to you? If it isn't, it's really familiar to your patients and to the patients I happen to know about. They call their clinics and say, hey, on the telehealth policy update page, it says it's going to expire on September 30th. Like, I need to reschedule. right away because my next appointment in October is a telehealth appointment. Okay. All right. So we're going to remain flexible, optimistic. Okay. Maybe not so optimistic. The September 30th telehealth cutoff in Congress. Now, we've received multiple reassurances that telehealth is going to be continued because it's a bipartisan issue. Everyone loves telehealth. People across the aisle have stories about how their elderly relatives received exemplary care, got their Paxlovid, got their whatever during the pandemic, had their hypertension managed. But I haven't seen any bill yet. Congress is out. Today is the 12th, so they're on recess. They're going to be back in session on September 2nd. This is where's our Congress? When are they going to meet type of calendar excerpt here. And per this published calendar, there are 12 House working days and 14 Senate working days. So where do all good bills start? They start in the House. We're gonna remain optimistic. It's a bipartisan issue. It may be extended. It will be extended. Okay. This is my prediction. Magic 8 ball. I don't know. I just don't know. I want to be positive, but I want to be, you know, I just want to be realistic with y'all. What does it mean for you and your patients if no continuance is passed? Do not pass go. Do not collect telehealth reimbursement. The location for medical appointments will revert to pre-pandemic, pre-PHE locations. An office, CAH, RHC, FQHC, hospital, hospital-based dialysis center, SNF, CMHC. And a hospital also means hospital outpatient department clinics. Now, these are the locations that are also pre-pandemic ordained. An RD facility only for the purposes of the home dialysis monthly ESRD related clinical assessment. So you'll be able to have a telehealth encounter there as long as you are receiving or performing your own home dialysis, but you come in and your provider is distant at the distant site and the renal dialysis facility is the originating site. Again, home of the individual for home dialysis, mobile stroke unit, the home of an individual for SUD or a co-occurring mental health disorder or just a mental health disorder. Just a rural emergency hospital. That's a new type of place we can all be thankful for. Rural emergency hospital became a distance site provider. And the home, again, here's the home of the beneficiary for diagnosis, eval, and treatment of mental health disorder. What I want to say, oh, yes, and also emergency departments if it's for stroke. Now, this mentions mobile stroke unit, but also an emergency department within a city if the distance site provider is a neurologist treating or diagnosing a patient for stroke if that facility does not have a neurologist on staff. And how are we going to know if any of those locations, barring home, ED, SUD, ESRD, are eligible for reimbursement? If you're a distance site provider in Phoenix and you're seeing patients out at the rural critical access hospital out in, gosh, where do I want to say? Not Barstow. I'm blanking on my cities around Phoenix. Anyway, oh, let's say, oh, my patient's in Tucson. How convenient. So you input, and that's at a clinic. That's not a patient's home address. Don't get lured. Don't get don't get stymied. I'm going to input the address of the clinic. It's a geocoded address because I don't know, it's where things fall via satellite and da da da. Okay, Tucson is a metropolitan statistical area. It is an MSA. You don't get telehealth payment if you see a patient at that clinic in Tucson. So just keep it in the back of your mind. Keep your fingers crossed. It's going to extend. I know we're talking about the MPFS, but just getting this out of the way. Behavioral health, home's a permanent site. There's a few caveats that might click in as of October 1st. Now, if you were seen at least 6 months prior to the telehealth visit in person, you get grandfathered in if you've already started telehealth visits during the pandemic. That's what that couple of slides back, it said during the emergency. Oops. So once in person, every 12 months thereafter. Now, don't complain to CMS, don't complain to Medicare, Medicaid, Medicare about this requirement. This is hard coded into the Social Security Act. So if you want this go on as a behavioral health provider, you got to talk to your congressperson. Say, you know what, let's amend that just a little bit more. Okay, just a quick statement about the DEA and Health and Human Services. The full set of telemedicine flexibilities have been extended through the end of this year with prescribing controlled meds. So that's not going to end on the 30th. It's going all the way through the end of this calendar year. You might have seen the newsletter that came out for Center for Connected Health Policy today about how we're coming up on that deadline. Yeah, if you haven't gotten that newsletter yet, go to the website, sign up for the newsletter, and you'll see that there's some commentary about how we're coming up on this deadline for where they have to publish the new rule. And we get to comment on it for 60 or 90 days prior to them implementing it. So time's getting tight. Okay, can FQs and RHCs continue to use telehealth? Yes, through 2025. Now, if the extension ends, these types of providers will no longer be eligible as an eligible provider. An OT, a PT, an SLP, and an audiologist. Now, I'm kind of confused why in the MPFS they came up with a new audiology code that can be done via telehealth, but maybe that would be for an ENT medicine provider instead of an audiologist. More work on the physicians and the nurse practitioners and the PAs. I don't want to leave anyone out. Anyway, there is legislation pending about all of these types of providers. They're October 1st, put on the brakes. Now, this slide you've seen before, just details after September 30th, how to bill based on where you're located, how it's going to affect your reimbursement. Now, if they've changed the definitions. O2 used to say, an eligible blah, blah, blah facility. It's just now it's telehealth provided other than in a patient's home. But it does say the patient's got to be at an eligible originating site. And those originating sites, think back to those eligible sites now, hospital, FQ, CAH, in a geo-coded located area that is outside of an MSA. Okay. So the patient location, you have to be in that HRSA approved. Well, it's not HRSA approved. It's just based on census data and the physician shortage areas. Got to be way out there, way out. The provider location is wherever they are. If it's an O2, place of service code, you only get paid the facility professional fee rate. It's not as much money as if the patient were in their home. Like now, we're all billing place of service 10 because everyone's talking to their patients in their homes. It's going to end for medical services. If you're off campus HOPD and the patient's at home, this is what happens when you mess with strangers. I'm just quoting the Big Lebowski. You don't get reimbursed anymore. This is what happens after. So say I'm a facility person located in an HOPD. I usually bill place of service 19 or 22. And patients at home, I don't get reimbursed. Go back to the olden days for Medicare beneficiaries of billing the CPT code, popping the GY modifier on there because it will no longer be statutorily approved. Again, here we're getting paid the non-facility rate. It's amazing. Everybody, medical management, behavioral health, we're making bank. Afterwards, no payment. Call your Congress people, write your letters. Really, I think bugging your House of Representative folks more so, since they have less days in session than the senators, would be a good thing. All right, enough about that. I've spent 15 minutes talking about that. But it's important because we love telehealth, even in cities with a fox in a box in a tree. Well, I live in California, so Medi-Cal would pay for a telehealth visit if I was in a box in a tree, to quote Dr. Seuss, a different kind of doctor. But we love telehealth. We want to continue providing it for our patients. We want to keep them well. We want to keep them from getting admitted to the hospital because they're not getting timely treatment and diagnosis. Okay, soapbox. I'm descending. Okay. This is a weird one. The conversion factor proposal this year. I had to go into the Wayback Machine. I had to go back. All right. I'm going to talk about budget neutrality first. Again, I talk about it a lot. Maybe, probably I do. We have to maintain budget neutrality. They expect that each year it's going to cost $20 million more each year. May not cause to differ by more than 20 million from what expenditures would have been in absence of these changes. Anything more than 20 million, your specialty RVUs are getting cut. Maybe PCPs are getting more because of advanced practice, evaluation, and management now, advanced principal care management. Maybe if you're a neurologist, it's going down. So it's a balancing act. It's not even spinning plates. It's just like knocking plates off, putting them back out on shorter sticks. So there are two paths coming up in 2026. There is the Medicare Access and CHIP Reauthorization Act effect in 2026. If your providers, if you as a provider or your facility is a participant, your facility in terms of being your employer, and they've enrolled you into an alternative payment model, you get $33.59 per RVU. If you're going to not participate and it's straight fee for service, it's $33.42 per RVU. It doesn't seem like that big of a deal until you start getting into those higher RVU CPT codes like 99215 or 99205. That's like 7 CEUs. Now you multiply that, all of a sudden you're talking, dollars. So I had to explore this MACRA thing. I was in the compliance office way back then when it was implemented. Actually, I left compliance right when this went into effect, and I moved over to the wonderful world of telehealth policy and reimbursement. And it's here. It's actually here. So in 2015, this was part of, what they announced back then. We're going to go into quality-based care. These fee schedule updates, you got incentive payments up until 2024. And then you also got, the incentive payments for different types of things that you would report, different modifiers, different HCPCS codes indicating that. I did ask all of my patients that day about smoking cessation or if they had ever smoked. I did ask them about their glucose. I mean, there are certain performance indicators that a patient might think to be, I want to say superfluous, but that's not the way you pronounce it. This is what I get for reading too much. Superfluous? There we go. But since I get an incentive payment for that, or I don't get penalized, anyway, this is why now they're splitting into two different conversion rates. So what this means per specialty is, all right, this is table 92. I did kind of, I didn't steal the exact slide, but I do love the PYA webinar series. And I did include a URL for that series on my reference slide at the very end. The two attorneys that speak about the impacts of the MPFS are amazing, and they're much more eloquent about this than me, so I should not spend that much time talking about it. But it is important, depending on what kind of practice you are in or what kind of practitioner you are, you're going to have impacts upon your specialty, because the people that are in a non-facility, let's say, are getting an 8% increase. Impact of what they did was they took practice expense and they afforded more of the practice expense. Now, this is all part of the conversion factor. They took more of the practice expense and loaded it onto non-facilities and took it away from facility-based, because facility-based clinics, hospital outpatient departments, it's split fee, it's split bill. So a hospital-based department gets less money for the pro fee anyway, but the facility gets to bill a facility fee to the tune of about $200. So what they're doing in this year's conversion factor, in addition to the MACRA machinations, is making sure that sole practitioners, how many are left anyway, are getting more practice expense money percentage wise than a facility based provider. So allergy immunology, getting 8% more this year. A facility-based allergist, immunologist is getting 11% less. What? I know. Anesthesiology. So I'm thinking, pain management, whatever else they're doing in clinics, these anesthesiologists, they're getting 3% less. Now, anesthesia is on a different pay schedule. You won't find it in the MPFS, but because it's unit based and all this fancy stuff. But they're getting 3% less. I don't like that. I love anesthesiologists. They've kept me alive for every single surgery I've had in the last 6 years. And as you all know, I have had many. Emergency departments, 2% less. What? Okay, endocrinology. I love my endocrinology guys. They keep my thyroid happy. They're getting 10% less. Hem-onc, seriously? Hem-onc at a facility? How many hematologists do you know are practicing in a standalone clinic? 11% less. Okay. Okay. Criticism and sarcasm aside, if you are in, of course you're in a specialty, take a look at table 92 within the proposed rule of this year, and I've got the URL at the end. Take a look at it and see how it's going to overall impact, and write a comment letter saying, I appreciate what CMS is addressing in terms of payment equality between clinics and facility providers. However, okay. So yeah, budget neutrality. They're also making gypsy adjustments. Geographic, it's wherever you're located. Where I am in San Francisco, the providers here get more than the providers in Tucson. Cost of living. Malpractice insurance costs more. Practice expenses cost more. Oh, but guess what? We're getting it cut by 11%. Okay. Efficiency adjustment. I didn't address this, but again, the better you are at something, the less money you're going to get. According to CMS, you can do it faster. Practice expense methodology. Yeah. Increase in physician employment. This is a very astute comment that the PYA people said. It didn't take into account an increase in physician employment and decline in privately practicing physicians. Like, how many people do you know that are not like on staff now at Kaiser or within a medical group that is contracted with a major medical center? A few critical access hospitals, perhaps. And then there's greater indirect cost for office space versus facility. Okay. Place of service matters. And matters. It does matter. Okay. This is the comparison of reimbursement for professional fee provider for fee for service, not a non-AMP rate. So I'm basing this on $33.42, not $33.59. So currently, a facility provider and a non-facility clinic bills place of service 10 for home-based telehealth care for patients. The conversion factor of 33.42 and the current RVU of 5.33, I think that's going up in 2026. No, wait a minute. No. This is 5.33. This is the 2026 total RVU. You can download the proposed RVUs. That's another thing. Download your proposed RVUs and see how it's going to affect your clinic and comment accordingly. Medicare, it's CMS, they're required to read every comment letter. Private citizen, I'm going to write a letter. Okay. Anyway, so you get $178 next year. This is an average price. It's not based on any geographic location. Look at the difference. So place of service two, if the patient has to be back at a facility, you're only going to get $117.30. And guess what? You're not going to get a facility fee reimbursement because that's not part of it. They're not considering OPPS, outpatient prospective payment system. They're just, CMS is saying, well, it's physician effort. Well, if it's physician effort and practice expense, they're they're giving and worthily and appropriately people with freestanding non-facility clinics more of a practice expense, but decreasing it from a facility. So, oh, wait, but the RVUs are going down. The total RVUs are going down. So instead of 5.33, it's 3.51. Now I know you got to make sure if you're in an RVU based reimbursement system to make sure that they're basing it on work RVUs and not total RVUs, because that's a problem. But it's a big difference. And again, 99205, very common new patient CPT code, $237 as opposed to 160. 97091, that is a new behavioral health encounter or reassessment encounter for a non-MD, so not a psychiatrist. $173, 137 for behavioral health with medical intervention, medical management, $202 versus $159. Just saying, it matters. It matters where you can bill and where you're located. I always think of the REM song, Stand in the Place Where You Work. Okay. All right. What about all that other stuff? They're not telehealth services. They're not on the Medicare telehealth services list. Ergo, they're not telehealth. They are virtual. They can be virtual. They can be asynchronous. There are many aspects that are virtual, but they're not telehealth. Telehealth is a real-time face-to-face encounter over telecommunications machine equipment. So with any of these, and this is for some vendors out there or people thinking about doing RPM, you have to build the services, chronic care management, principal care, with a brick and mortar place of service code, i.e. non-facility clinic, which is 11, or 19, off-campus hospital outpatient. A lot of, I'm going to try to petition CMS to create a new place of service code that will afford purely virtual providers to be able to do these services without having a contract with a brick and mortar. We'll see what happens. We'll see if I finish it. Okay. All right, proposed telehealth changes, the good, the bad, and the not so attractive. I didn't want to get in any trademark or copyright infringement. Okay, the good. There is good news for us. There's a new way to get codes on the Medicare telehealth services list. Well, it's a new old way. The 5 steps where they introduced 2 additional steps last year, they're taking them away. So it's back to the original, sort of. So first, make sure it's on the reimbursement list that you can download at the URL I'm providing you. Determine whether the service is subject to the provisions of Section 1834 of the Social Security Act, the Act. Review as described by the HCPCS or CPT code and determine if you can even do it over an interactive telecommunication system. Stitching together a wound maybe if you're in Alaska in the wild and there's nobody around, I don't even think that would work. And they're not putting any new codes on a provisional versus permanent status. If you want to suggest any codes, go to the telehealth. So Google Medicare telehealth services list. It's going to take you to the webpage, and there's a URL there. There's an email address to submit, to request that a CPT code be included on the list. And the deadline for that is February 10, deadline for review for next year. So get it in by February 10th, mull it over, and then they're going to address it in the proposed rule for 2027. You can affect change. You're good like that. I have faith in all of you. Okay. The good and the bad. Sort of good, sort of bad. Okay, deleted services. This is from the proposed rule. We're proposing to delete HCPCS code G0136, which is an assessment for social determinants of health. Social drivers of health code. It is currently on the list, so it is also being deleted. I'm in favor of this code, G0136. However, in its discussion later on, or again in the rules somewhere else, it's saying that these issues should already be addressed in the management portion of the evaluation and management service that providers engage in with a patient. So maybe you take a PHQ-9, you can bill for that. It's $5. Maybe you also do some kind of other behavioral health assessment. You can bill for that. But social determinant of health, we're not assessing for that anymore. Even if you provide the questionnaire after painstakingly explaining to someone it's not any reflection on them or their lifestyle, we just want to understand how to help them better, you're not going to get paid for it. I think it currently pays around $10, but it's an incentive, right? Anyway. Okay. Services proposed for addition. There we go. There she is. They're going to add, get out. Thought we were going to make it, gang. Multi-family group psychotherapy, multiple family. So if you have a bunch of families together, all talking about patients that are depressed, you can bill for it via telehealth now. That's awesome. Group behavioral counseling for obesity. This is a weird little typo that is in the MPFS. Maybe they'll correct it in the proposed one. It's just a formatting issue. Group behavioral counseling, 2 to 10 people. Infectious disease add-on, inherent visit to inpatient. That can be done via telehealth. I'm not even going to talk about the G0545, but note that it was introduced last year. And if there's an element of infectious disease or an infectious disease provider is engaged in assessing and managing a patient's care in an inpatient setting, bill G0545 in addition to. Auditory osseo integrated sound processor. No audiologist can treat after the PHE or after the extension is over, but maybe this osseo integrated sound processor is performed by an ENT. So these are new codes. They're going to show up. That's it. There's no other deletions. So these are proposed permanent change. There's no frequency limitations on these following codes. And this had been carried over through September 30th. Now this is permanent forever and ever. Used to be 3 days or every other day. You can see a patient, inpatient, every day while they're admitted and bill a 99231 via telehealth if they're in a critical access hospital. This is critical care consultations, not critical care. So not a 99291, not a 99292, a G0508, which is 1 complete hour of consulting at bedside with a provider at bedside remotely. Okay. All right. So that's the list. I want to get into supervision. Just for a brief detour. There are 3 supervision levels. I wanted to put this slide in just because we're like, what? Okay, I had to explain it to myself. So I thought, well, if I have to explain it to myself, what about the people on this webinar? You need to know what it is too, because general, there's no physician presence required. Someone's carrying out a care plan, like chronic care management is general supervision. There's a care plan in place, and as an RN in the clinic, I am going to perform services for the patient, call a pharmacist to talk to them about medication or whatever. There's a care plan, there's direction given. Provider does not have to be on site. Direct, you got to be within calling distance. Personal, in the room, got to be physically present in the room during the procedure. This usually means, let's say you're stitching. Oh, let's go back to the stitching. You're stitching someone up. That is a minor procedure. Attending physician has to be in the room with a resident or a fellow 100% of that time because it's minor. Okay. Currently, the good. So virtual direct supervision, this is what's currently allowed. Incident 2, physician services, when provided by auxiliary personnel, meaning you're employed by the physician and working under direct supervision. And I had to look up PCTC indicator of 5. It means incident 2, codes are not subject to pro fee or tech fee payments because they're bundled. They're incident 2 another service. Or 99211 if you're in a clinic, a non-facility clinic. Now, there are ways to bill 99211 incident 2 at a facility, HOPD. There has to be an order in place, doesn't there? Yes, there does. Or if it's under general direct supervision, it's billed out by the facility. Okay. They're going to extend these next year. Exclusive of audio only. You can still provide direct supervision past the end of this year for anything that does not have a 10 global days or 90 global days. So this is bringing in surgery procedures as well. They're contemplating virtual direct supervision, such as endoscopy, things that have 0 global days. It's still a procedure. There's still maybe sedation involved, like an endoscopy or a colonoscopy, 0 global days. You are not, if you follow up with your gastroenterologist 2 days after a colonoscopy, they are not held to surgery bundling. They can bill an E&M visit. 0 to 10, or this 10 days after, that's usually suturing, stuff like that. This is the same for FQs and RHCs. And then they're also going to extend direct virtual supervision for cardiac, pulmonary, and ICR. Great. This is when the patient is located somewhere doing, I don't know, spirometry test, exercise-based ICR, cardiac. I'm thinking you're interrogating a pacemaker. Not so attractive. Taken away, teaching physician supervision, can't bill anymore. And I think this is the crux. I've looked at other materials, I've read other takes on this. It's really, they're not so convinced that the teaching physicians are actually interfacing with the patient so much on these video calls. So it does not allow for the teaching physician to bill. You can still do it. You can still use it as a teaching opportunity. But if there's going to be a GC modifier on that encounter and there was a resident or a fellow involved, and you have not documented your own separate entire note by yourself as of October 1st, I know this is mixing MPFS and the end of the extension together. But rural settings, yes, because you don't have doctors out there as much. If you're serving it as an originating site, I'm at an FQHC in a statistically allowable area, and I get to bill 31. I get to get paid $31.85 to host that patient. So it started out at $20. It's gone up 60% since 2001. I didn't even look up what the cost of living went up since 2001, probably 160%. I don't know, triple that. Okay. If Congress does not pass an extension, CMS is proposing G2025 can still do telecommunications, medical visit service through the end of 2026. So it's not under the air. It's not under the PIP or whatever. It's going to be based on services paid under the PFS, weighted by volume for those services reported. So if it's an E&M visit, they're going to take the average of G99202 to 99215, take the average of that, pay that for the G2025. That's for the end of 12/31/26. You guys, luck out. Luck out, man. Okay, so beginning October 1st, unless this is included in the extension, this is also for FQs and RHCs. You must have an in-person mental health service furnished within 6 months prior to the initiation of audio, video, or audio only. Again, if this started before the pandemic, public health emergency and subsequent extensions, it's once every 12 months. And it gives this nice caveat, I guess, as long as you don't wear it out. I don't know, there's a snowstorm and I can't come down off the mountain to get to the clinic for that in-person visit during the month of December because I'm snowed in. Doesn't make sense. Document it, bill it. Okay, considerations for virtual care options. RPM, everyone's excited. We're excited. There's a new code for 2 to 15 days for billing, monitoring, and for reimbursement on the device. Now, this is the education code. Get to bill it once per episode of care. Does not have to happen within 30 days, but it does require 16 days over a period of time to report the code, get reimbursed for that education. You did the service, but I guess they want to make sure it's being used. Okay. So that education had value. 99XX4, 2 to 15 days, within 30. All right. So monthly management, they're giving you credit for 10 to 19 minutes. I only looked at the code. I only looked at the stuff when there was an alarm on a certain patient's monitoring system on the dashboard. It only took 15 minutes that month instead of 20 cumulative minutes. Bonus. These pay roughly 50% of what these codes pay. Same thing with RTM. 2 to 15, 2 to 15. This is musculoskeletal, respiratory, cognitive behavioral therapy. There's no reduced days code. Gosh, this is a good code. Let's ask for one. Monthly management, we get 10 to 19 minutes similarly to RPM. All right, submit a comment. As of 3 days ago at midnight, there were only 1,500 comment letters submitted. I think the year prior, there was like 20,000. I might be exaggerating. Anyway, they're required to read your comment. You have lots to comment about. You have thoughts. You have your rights to have, as you know, as a provider that is contracted with Medicare to provide services to its beneficiaries, you want to make sure that you get a say in the matter. This is like a contract negotiation with a commercial, asynchronous contract negotiation. Some things I think are important. RVUs, any services being added or deleted, SDOH. And then, you know, I would also hazard a comment, or I would suggest one for cognitive behavioral therapy. They're still kicking that to the curb as contractor priced. Price it like the other ones, at least. Don't make us fight for this. Don't make the Macs do any more work. Anyway, deadline is September 12th, 2025. And don't forget about that other October 1 occurrence. There's new ICD-10 codes. There's 487. A lot of stuff. I didn't even look at the specific codes under injury, poisoning, external. That would be a whole other webinar. But you know what? It matters. It matters because AI is now data trolling, data kind of thinking about in the Matrix, how those little machines are flying around, picking and choosing. They're picking out ICD-10 codes to see if what you are billing validates the level of service. So be as specific as you can and as correct as you can be. So if your services, if you're a poison, who's a poison doctor? Internal medicine? You know, if that's a lot, there's a lot of injuries. There's a lot in there. I wonder if there's anything to do with like being stalked by a turkey or some of the other strange ones that come in every year. That's awesome. That's actually already a code. But there's a lot with skin and subcutaneous tissue. Oh, and if you're a skin person, they are slashing the price for substitute skin. Take a look at that, make a comment. It's no longer being paid. It's just at a big rate. It's slashed. So yeah, take a look at these. These are in effect on October 1st. So make sure your charge masters and whatever are updated. It's a lot. If you're a GI person, you get only 5. But there's some new symptoms codes, the R codes. There's 20 of them in there. There's more Z codes for SDOH, even though we're not getting paid for that anymore, evidently. So, what are you going to do? Hope for the best, prepare for the worst. It's lunchtime. Change what's on your care menu. Look into RPM now that we've got those different dates. RTM, CCM, PCM, TCM, PIN, CHN. Contract with a brick and mortar clinic or a vendor to help you out with all this different care management we're moving towards. Oh, yeah. And they want to improve global surgery payment accuracy. I know I get on a thing about 99024. Bill it with a TC mod or a 993 or a 95 modifier. Okay, what was left out? This is important. I know I'm really going over. I will answer every question offline. They didn't comment that they're not talking about this in the MPFS. Bring it up. So if you're a telehealth provider and you work out of your home instead of going back into the clinic to do your telehealth services and tying up exam rooms, they're not saying anything about keeping your home address off your enrollment information. Or box 32, which is where the service location is input, which is going to be your home address. So without any extension proposal, it's going to end January 1st. Comment. Here's the link to find the proposed MPFS. There's a link on that page to take you to where you comment. And here are your resources. And I have 2 minutes for questions.
We do have a couple of questions. First of
Okay.
all, just to let everybody know, the slides will be available on our website. You will get that URL in the thank you email. The first question was early on, do FQHCs fall under facility or non-facility?
They are facility.
Okay. The next one we had is, will school-based telehealth programs using school campuses as telehealth locations continue as an approved site if the PHE extension ends?
It depends on whether or not it's based in a geographically, a HRSA-based geographic location.
Okay.
So you got to type in that location. And also that's going to fall under Medicaid. So I would contact your Medicaid carrier.
Okay. Let's see. And all right, I think that I addressed the other issues we've got. Yes, the webinar is being recorded. And any other questions? Now, granted, when I send out that thank you email, everybody, if a question comes to mind, go ahead and respond back to me, and I can get it to Carol as well, and we can work on that offline. But like I said, this has been recorded, and I will send out the URL link that'll be on our website a little bit later today once it gets processed, and you will be able to get a copy of these slides. So we are right on time. You blew through those 54 slides.
And thanks for everyone's attention. I didn't see anyone leaving. I mean, I know you're getting to see me for it, but I appreciate it. I do look at the numbers. I can't help it. I'm like, oh no, they left, you know.
No, so we've got plenty of people that have continued to stay on for the entire time. Greatly appreciate everybody joining us today. And like I said, if you have any questions, please go ahead and respond back to my email. And please do that evaluation so Carol can get more questions and more time, camera time in front of you answering them. All right, so thank you again, everybody. Have a great rest of your afternoon, and we'll look forward to seeing you at the next webinar. Take care, everyone.
Thank you.